Hello student, now we are going to discuss blood pressure and its regulation. So all of you know the definition of blood pressure, that it is the lateral pressure exerted on the vessel wall by the flowing blood, that we know. Now we also know that there are different types of blood pressure like systolic blood pressure, diastolic blood pressure, pulse pressure and the mean arterial pressure. So we have to understand all of these different types of blood pressure and what are the determinant of these different types of blood pressure. So first I am writing systolic blood pressure. The two main determinant of systolic blood pressure are number one, stroke volume or cardiac output of the person, and second determinant is very important, that is compliance of aorta, that is compliance of aorta and major vessels, right? So how these two parameters are related to the systolic blood pressure? Systolic blood pressure will be increased due to any condition if the stroke volume or cardiac output is high, means systolic blood pressure is directly related to the stroke volume or cardiac output of the person. Similarly, if the compliance is lesser, then the systolic blood pressure will be more and more, means systolic blood pressure is inversely proportionate to the compliance of aorta and major vessels. I'll discuss that what is the meaning of this compliance and how it is related, okay? But for the timing, you remember the different parameter. Now the diastolic blood pressure, on the other hand, the main determinant of diastolic blood pressure is elastic recoiling force of aorta and major elastic tissues, right? And second determinant, all of you know this is nothing but TPR, total peripheral resistance or systemic vascular resistance. So how these are related? If the diastolic blood pressure high, that means either the elastic recoiling of the aorta or major elastic vessels are high, or the TPR or the total peripheral resistance is high, means both TPR and elastic recoiling are directly proportionate to the diastolic blood pressure. Now we'll come to this pulse pressure and mean arterial pressure a little later, but before that, let's try to understand all of these factors, that how this stroke volume and cardiac output is related to systolic blood pressure, how this compliance of the aorta is related to SBP, right? So to understand this topic, I am drawing a schematic diagram of the left ventricle. So this is the schematic diagram of the left ventricle. So from this left ventricle, this is the arch of aorta, right? So this is the arch of aorta which is originating. Now, we all know that blood pressure means nothing but it is the pressure which is exerted on the lateral surface of this blood vessel, right? So, whenever the stroke volume is ejected at the level of arch of aorta, it will exert some pressure at the lateral surface of this blood vessel wall, right? So, I can easily understand that if my stroke volume is more and more, if my stroke volume is rising, so it is going to exert more pressure on this aortic vessel wall. That's why I say that stroke volume more means if the stroke volume is rising, systolic blood pressure is also going to rise, and same for the cardiac output. More the cardiac output, more will be the systolic blood pressure, right? Now, all of you know the second part, that is the compliance of aorta, how it is related to the systolic blood pressure. So you know the compliance, the word means, compliance means nothing but stretchability, okay? Stretchability of the vessels. So compliance word meaning is stretchability. So if the aorta is stiff or hard, that means low compliance. Getting my point? So if the aorta is becoming stiffer, that means the compliance of this aorta is lesser. So what is happening whenever the stroke volume is ejected by the ventricle, arch of aorta also expanded proportionate to this stroke volume. There will be expansion of the arch of aorta because it contains huge amount of elastic tissue. So whenever you are ejecting stroke volume, what will happen? This arch of aorta will also get expanded. There will be expansion of this arch of aorta. Now remember, this expansion, more the expansion, more is the compliance, more is the stretchability. So whenever a vessel is expanding, it is absorbing the pressure. Getting my point? So expansion means it is dampening the pressure. So if the vessel wall becomes stiffer, so it is not able to expand, it is becoming stiffer, it is becoming hard. That means the compliance of the vessel is low. So what do you think? If the same stroke volume is ejected in this condition, the vessel is not able to expand, the vessel is not able to absorb the pressure. So what will happen to the pressure which will be exerted on this wall? Obviously this pressure is going to be exerted more. That means more stiffer the vessel wall, more harder the vessel wall, the same amount of stroke volume is going to exert more pressure. That's why I told you that systolic blood pressure and compliance, the relationship is inverse. Lesser the compliance, more will be the systolic blood pressure. This is very important. I will give you one clinical example just after this, but first try to understand the different determinant of this systolic blood pressure. Right. Now coming to the diastolic blood pressure. So I told you that diastolic blood pressure, the determinant are elastic recoiling of the arch of aorta. So the similar kind of schematic diagram, the left ventricle and the arch of aorta, right? So whenever the stroke volume is ejected, I just told that this arch of aorta is going to be expanded like this. Okay, expanded like this. Now, diastolic blood pressure, by definition, it is the blood pressure which is exerted on the vessel wall during diastole of the heart. Like systolic blood pressure, that is the blood pressure which is exerted during systole. So here, the ventricle will be in the stage of diastole. So during diastole, we all know that this semilunar valve will be closed and the ventricle will relaxes more and more. That is the diastole, right? So if I ask you that during diastole, ventricle is not ejecting any stroke volume. So what do you think? The blood which is present in the vessel, that is going to flow or not? The flow will stop. Obviously the flow is not going to stop. The flow is continuous. That means I can understand that although these semilunar valves are closed, no one is pushing the blood from ventricle, but still blood flow is continuous inside the vessel even during the diastole of the heart. So question is, who is pushing the blood from behind so that there is continuous flow even during the diastole of the heart? Getting my point? That is the biggest question. So during diastole, somebody is pushing the blood, because of which the constant blood flow is maintained. Now, why this constant blood flow is required? Suppose the blood flow is completely stopped. What do you think? What will be the pressure on this vessel wall? The blood pressure will be how much if the blood flow is completely stopped? Suppose there is a sudden cardiac arrest. What will be the pressure inside the vessel? Do you think that will be zero? Answer is not zero. That will be near equal to 7 millimeter of mercury, and this blood pressure, this pressure is known as the mean systemic filling pressure. Mean systemic filling pressure, right? Please remember this name, mean systemic filling pressure. Okay, so whenever the blood flow is stopped, okay, the pressure that will be exerted on the vessel wall is very minimum, but that is not zero. That is near equal to 7 millimeter of mercury. That is known as mean systemic filling pressure. Okay, now we all know our diastolic blood pressure is 80 millimeter of mercury. That means it is way above this 7 millimeter of mercury. So that means blood is flowing even during diastole, and that's why the pressure is not 7. It is more than 7, and that is near equal to 80 millimeter of mercury. So my question is that whoever is maintaining this constant blood flow, that is the major determinant of this diastolic blood pressure. So now look at who is maintaining this diastolic blood flow. So whenever the stroke volume is ejected, I told you already that arch of aorta will be expanded. Whenever this semilunar valve is closed, this arch of aorta is going to be recoil back. Now whenever the arch of aorta is recoiling back, it is going to exert some pressure on the blood which is present at the level of arch of aorta. Because of the pressure, what will happen? This blood will be pushed forward. And again, when the blood is reaching here, again it will causes elastic expansion of this vessel wall again, right? And again this vessel wall is going to be recoil back. Whenever it is recoiling back, again it is going to push the blood in the forward direction, and again the same thing is going to happen. That means this blood is going to cause expansion of this vessel wall, and again that vessel wall will recoil back. So that way I can understand that there is an elastic expansion followed by recoiling, elastic expansion followed by recoiling. A wave is going through this vessel wall, this expansion, recoiling, a wave is going through the vessel wall, and this wave you can feel at the level of artery, this expansion and recoiling, and that is nothing but your pulse. Getting my point? So basically the pulse which you feel at the level of artery, whether it is radial artery or any artery, that is nothing but due to elastic expansion and recoiling of the major arteries and arch of aorta. So whenever the arch of aorta is expanding, okay, then it will recoil back, and that is pushing the blood, and that pushing means the blood will move in the forward direction. Again there will be expansion, recoiling. This way a wave will travel through the arterial tree, and this velocity of this wave is very fast. It is 15 to 35 meter per second. This means this pulse wave velocity is running at a very faster rate through the arterial wall, and whenever you feel here, okay, you can easily feel the arterial expansion and recoiling. Getting my point? So now I can understand that even during the diastole, some force is pushing the blood, and that force is nothing but elastic recoiling of aorta. And that's why I told you this has been asked in AIIMS entrance examination, that what is the major factor for diastolic blood pressure. Your answer is elastic recoiling of aorta and the major vessel. More the elastic recoiling of aorta, more will be the diastolic blood pressure, right? This is the important thing. Now second thing is that if there increase in peripheral resistance, so suppose there is increase in resistance of this vessel, that is the peripheral resistance. We have discussed in hemodynamics what is the meaning of peripheral resistance. So whenever this resistance is increased, I can easily understand, okay, behind this high resistance portion there will be accumulation of a little more blood, so that is going to exert more pressure on this vessel wall, and that's why we say that more the total peripheral resistance, more will be the diastolic blood pressure, right? Diastolic blood pressure. So that's why we can understand the diastolic blood pressure determinant are two, that is TPR and elastic recoiling of aorta, right? Okay. Now coming to the pulse pressure. Now pulse pressure, all of you know that it is nothing but difference between this systolic blood pressure minus diastolic blood pressure, right? So difference between SBP minus DBP is nothing but our pulse pressure. We all know that. But you remember that ratio between stroke volume and compliance of aorta, ratio between stroke volume and compliance of aorta is also the pulse pressure. Getting my point? So this is clearly written in Guyton that the ratio between stroke volume upon compliance of aorta is the pulse pressure, right? So we have to understand why the ratio between stroke volume and compliance is equal to pulse pressure, right? So again the same diagram I am discussing here. So this diagram we have already discussed that whenever the stroke volume is ejected, the arch of aorta will expanded, and then there will be recoiling during diastole. Now my question is, I want to measure what is the compliance of this aorta. I want to measure the compliance. I told you compliance is inverse of elasticity. Compliance is equal to stretchability, right? Compliance is equal to stretchability. In respiratory system, you will understand this formula a little better way, but for the time being, remember the compliance is equal to stretchability, and it is measured mathematically by delta V upon delta P formula. So delta V is the volume change and delta P is the pressure change. So if you change a unit amount of pressure, how much volume change is going to happen? That is the measure of compliance. So if you change a little amount of pressure, how much volume is changing? That is my compliance. So I want to measure the compliance of this aorta, right? So what I need to measure what is the volume change of this arch of aorta, and for that volume change, how much pressure is changing, right? So during systole, the stroke volume is ejected, and because of the ejection of the blood pressure which is exerted here, that is nothing but the systolic blood pressure. And when the semilunar valves are closed, then the pressure which will be exerted on this vessel wall, that is the minimum pressure, that is nothing but the diastolic blood pressure. We have discussed already that systolic blood pressure means maximum blood pressure which is exerted during the systole of the heart, and diastolic blood pressure when the semilunar valves are closed. So if I ask you that how much pressure is changing at the level of this arch of aorta during systole and diastole, I am asking you that tell me how much is the delta P, how much pressure is changing at the level of arch of aorta between systole and diastole. So during systole, the pressure will rise to systolic blood pressure, and during diastole, the pressure will decrease to diastolic blood pressure. That means the change of pressure or delta P at the level of arch of aorta is between systolic blood pressure, diastolic blood pressure. Systolic, diastolic, that is the change of pressure. If I ask you why this pressure change is occurring, your answer will be that this is due to ejection of this volume. Which volume? The stroke volume. Because you are ejecting stroke volume, that's why the diastolic blood pressure is rising to systolic blood pressure. That means I can understand that at the level of arch of aorta, the volume change is occurring that is equal to stroke volume, and because of this volume change, the pressure change that is occurring is SBP minus DBP, and SBP minus DBP is nothing but the pulse pressure. That means in this compliance equation, I can easily put that stroke volume upon pulse pressure is the compliance of aorta. So I can easily say that pulse pressure is equal to nothing but stroke volume upon compliance of aorta. Getting my point? So that's why the Guyton is writing, okay, although the explanation is not given, but Guyton is writing that stroke volume upon your compliance of aorta is nothing but your pulse pressure. Got it? So this is about pulse pressure, right? Now the last one is the mean arterial pressure. Now whenever we are saying mean arterial pressure, by definition, we know mean arterial pressure is nothing but average pressure throughout the cardiac cycle, right? So during cardiac cycle, blood pressure will fluctuate, systolic blood pressure, diastolic blood pressure. But if I take an average, if I take a mean, then what is that blood pressure? That is known as the mean arterial pressure. Generally, we say that mean arterial pressure is equal to cardiac output multiplied by total peripheral resistance. If you do, then you are going to get your mean arterial pressure. But both of this measurement is difficult. So that's why we used a simplified formula, and that simplified formula is diastolic blood pressure plus 1/3 of pulse pressure. Diastolic blood pressure plus 1/3 of pulse pressure, and that will be equal to 2/3 of diastolic blood pressure plus 1/3 of systolic blood pressure. Getting my point? So now if you look at the equation, the mean arterial pressure is equal to 2/3 of the diastolic blood pressure and 1/3 of the systolic blood pressure. Means although we are saying it is a mean pressure or an average pressure, but we are not taking the average, because if you are taking average of systole and diastole, then it will be D plus S upon 2. But here we are giving more importance to the diastolic blood pressure. Why? Okay, because you know, I told the mean arterial pressure is nothing but average pressure throughout the cardiac cycle. If you look at the duration of the cardiac cycle, the diastolic duration is more 0.5 second, systolic duration is 0.3. So considering this duration, if you take a weightage average, then diastole should be given more weightage, more dominance, and that's why we are taking 2/3 of the diastolic blood pressure and 1/3 of the systolic blood pressure for the measurement of mean arterial pressure. So this is basically a weightage average, not the arithmetic average, because if it is arithmetic average, then the formula should be like this, but we are taking a weightage average. Diastole is given more weightage. Now, after discussing this mean arterial pressure, now I will ask you to recall one important topic that we have discussed earlier, that is aortic pressure curve, right? Could you recall that? So if you recall that aortic pressure curve, okay, so look at, I am drawing this curve. So this was x-axis and y-axis, and if you recall the Uyghur's diagram, if you recall the aortic pressure curve, it was looking like this. The aortic pressure curve was like this, okay? Percussion wave, then tidal wave, then dicrotic notch, and then dicrotic wave, and then the diastolic blood pressure, right? So suppose this is one cardiac cycle. Suppose this is one cardiac cycle from here to here, right? So this is T1 and this is T2. The time interval between this T1 and T2 is the cardiac cycle duration, right? So we know that in aortic pressure curve, this wave is known as the percussion wave, and then there may be a tidal wave, then this is the dicrotic notch, and then the dicrotic wave is here, and then this is the diastolic blood pressure. So in this pressure curve, the maximum blood pressure that is exerted during systole is this, this is the systolic blood pressure, and the minimum blood pressure that is exerted is the diastolic blood pressure, and the difference between this systolic and diastolic blood pressure, this is nothing but my pulse pressure, right? Now, if I have to calculate the mean pressure means average pressure throughout this time window T1 to T2. So what I have to do? I have to take the area under the curve. Okay, so I have to take this whole area under the curve, and then if I divide this area under the curve upon this time interval, then I am going to get the actual mean arterial pressure. Getting my points? What I'm saying? So I have to take the area under the curve. So how to take the area under the curve? Because it is not a bell-shaped curve, so I have to take an integration from T1 to T2 time point P dt, right, upon your T2 minus T1. If you use this formula, then you are going to get the exact mean arterial pressure. Getting my points? How difficult it is. So you have to first measure the pulse wave with the help of a carotid pressure transducer, and then if you use this formula T1 to T2 P dt upon your T2 minus T1, then you are going to get your mean arterial pressure, because it is an average throughout the cardiac cycle. But if you take the 2/3 of the diastolic blood pressure and 1/3 of the systolic blood pressure, then it is very, very close to the actual mean arterial pressure, and that's why we use this simplified formula of 2/3 of diastole and 1/3 of systole. But that is not the actual measurement of mean arterial pressure. It is very close to that. Getting my point? So this is all about the concept of mean arterial pressure and other types of blood pressure. Now, after discussing this, I will tell you one clinical condition, and you have to understand that what will happen in that clinical condition about pulse pressure, right? So first condition is the calcification of the aorta. Okay, so calcification of the aorta, right? The calcification may be pathological, or normally when the age is greater than 70 years, sometimes normal physiological calcification can also occur, right? So whenever this calcification of aorta is occurring, so I can imagine a diagram like this, that this is the left ventricle and this is my arch of aorta. So there is calcification at the wall of this arch of aorta. Tell me what will happen to the compliance of the vessels, compliance of aorta in this condition. It is low or high? Obviously the aorta becomes stiffer, so the compliance will be lower. Now whenever the compliance is lower, I can easily understand that if the stroke volume is ejected in this condition, suppose the stroke volume amount is normal, same amount of stroke volume is going to exert how much pressure? It is going to exert more pressure. And what blood pressure that is? That is nothing but the systolic blood pressure. So compliance is low means systolic blood pressure will be very, very high in this condition. So whenever there is calcification of the blood vessel, whenever there is stiffness of the blood vessel, you remember systolic blood pressure is going to be higher. Now think of diastolic blood pressure. So diastolic blood pressure, I told you that whenever stroke volume is ejected, then this arch of aorta will be expanded during this ejection of stroke volume, and then it will recoil back whenever your semilunar valves are closed. But in this condition, the arch of aorta is calcified and it is not able to expand. So if it is not able to expand, how it will recoil back? So if I ask you what will happen to the elastic recoiling force, it is not expanding. So obviously elastic recoiling force will also be less. And if the elastic recoiling force is less, I told you, more the elastic recoiling force, more is the diastolic blood pressure. Because the elastic recoiling force is less here, diastolic blood pressure will be low here. So your systolic blood pressure is very, very high, your diastolic blood pressure is low. What will happen to your pulse pressure? Your pulse pressure will be very, very high in this condition. Getting my point? So please remember, in case of old age person, or if there is calcification, there will be isolated systolic hypertension. Systolic blood pressure will be very, very high, right? But diastolic blood pressure will be low, and if you calculate the pulse pressure, it is going to be higher. Okay, the same principle is applied if you plot this curve, this aortic pressure curve. If you plot this aortic pressure curve from central artery and the peripheral artery. What I am saying? Suppose you have plotted this curve from this arch of aorta, this is the arch of aorta, and this is the artery, peripheral artery, and this is the arch of aorta. You have plotted this aortic pressure curve. So if the aortic pressure curve is looking like this at the level of arch of aorta, right, how it will look at the level of this peripheral artery? What will happen? These peripheral arteries are more harder, okay, more harder than that of the central artery. And this peripheral artery contain lesser elastic tissue than that of the arch of aorta, right? I told you that maximum elastic tissue here at the level of arch of aorta. So I can understand that this peripheral artery is more stiffer, means compliance is low, and elastic recoiling force is also low. So compliance low means systolic blood pressure will be higher, and elastic recoiling force means diastolic blood pressure will be lower. Alright. So if I record a pressure curve from this peripheral artery, it will look like this: peak systolic blood pressure and low diastolic blood pressure like this. So now you can understand that from center to the periphery, from the central artery to the peripheral artery, if you go, you are going to get a curve like this, that there will be increase in pulse pressure. Pulse pressure will be higher towards the peripheral artery. So what is the bottom line? Bottom line is that if you measure the blood pressure from a central artery and from a peripheral artery, if you record the pulse pressure curve from the central artery, from a peripheral artery have more systolic blood pressure and lower diastolic blood pressure. That means pulse pressure will be higher, right? So this concept you must have to remember. Now another concept. If I want to apply my concept in a patient of aortic regurgitations, that what is going to happen for the systolic blood pressure and diastolic blood pressure in this person. Okay, we have discussed this aortic regurgitation in our pressure volume loop, in our Weger's diagram, everywhere. So now let's discuss once again that what will happen to the systolic blood pressure and what will happen to the diastolic blood pressure. From your clinical medicine knowledge, you know that systolic blood pressure will be higher. So why that? So aortic regurgitation means this semilunar valve will not close completely during diastole. Means if I think of diastole first, then during diastole, some of the blood will flow back from arch of aorta to the ventricle. And ventricle, okay, obviously we are discussing left ventricle. Ventricle will also get its normal blood from this left atrium, okay. So it is also getting its normal blood from this left atrium. So two blood is coming at the level of ventricle, one from arch of aorta, one from left atrium. So what will happen to the end diastolic volume? It will be very, very higher. And we have already discussed, if the end diastolic volume is higher, stroke volume will be higher in the next cardiac cycle. So what will happen if the stroke volume is high? Just now we have discussed which blood pressure is going to be higher. Systolic blood pressure is going to be higher. So I can understand that aortic regurgitation patient will have higher stroke volume because the end diastolic volume is high. So arch of aorta will also expanded higher, okay, and it will get more pressure during systole. There is no problem in that. But what will happen during diastole? During diastole, normally the arch of aorta will recoil back, and that recoiling back will push the blood in the forward circulation, and the forward circulation will have some pressure, and that pressure is nothing but my diastolic blood pressure, right? That I told that someone is pushing. Who is pushing this elastic recoiling? But now you look at, whenever the recoiling of the arch of aorta is pushing the blood, most of the blood or some of the blood is returning back to the ventricle. So if I ask you, how much blood will flow in the forward part of the circulation, lower or higher? Low volume of blood will flow in the forward direction or in the distal part of the circulation. If the volume of the blood is low, obviously it is going to exert low pressure on the vessel wall. So what will happen to the diastolic blood pressure in this aortic regurgitation patient? It will be very, 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 very low. More severe the regurgitation back, lesser will be the diastolic blood pressure. Getting my point? So that's why again in case of aortic regurgitation patient, the systolic blood pressure will be high, the diastolic blood pressure will be low, pulse pressure will be high, similar to that calcification of the vessel wall. Getting my point? So please remember that diastolic blood pressure mainly depends on elastic recoiling of the artery. But you have to remember that during this elastic recoiling, how much blood is moving to the forward part of circulation. Okay, because that is ultimately going to exert pressure even during the diastole of the heart, right? So if that volume of blood is less, then diastolic blood pressure has to be less. Like for example, aortic regurgitation, patent ductus arteriosus, what will happen? Most of the blood is returning to the ventricle once again. So DBP will be lesser, right? So this is the concept that you have to remember about systolic blood pressure, diastolic blood pressure, pulse pressure, everything, right? So now I hope you got the concept of all of this blood pressure. Now before regulation of this blood pressure, I will tell you only one thing, that measurement of blood pressure, all of you know that we use the sphygmomanometer, that is known as the indirect measurement of blood pressure. But apart from that, the blood pressure can be measured by a direct method. Okay, all of you have must heard this kind of thing, that if you just put one catheter, okay, cannula directly into the artery, that is the intra-arterial method, that is known as the direct method of blood pressure measurement. And it is said this is nothing but the gold standard method, or this is the most accurate method of measurement of blood pressure, right? But we use the indirect method, and indirect method is nothing but the sphygmomanometer principle. Now there is a controversial question that sphygmomanometer measure more higher or more lower. Always remember, this intra-arterial blood pressure is always higher than that of the sphygmomanometer measurement, right? So please remember that intra-arterial blood pressure is always higher, means this direct measurement of blood pressure, it is always higher than that of the sphygmomanometer measurement, right? Okay, so this you have to remember. This is a controversial MCQ, remember this. Okay, now we are coming to the regulation of the blood pressure topic. Okay, so now we know different types of blood pressure. Now we are going to understand how this blood pressure is regulated. So as you can find out here, there are three major group of mechanism. Rapidly acting mechanism. This mechanism will start working within seconds. Okay, within seconds to minute. That's why they are known as the rapidly acting mechanism. Okay, then you can find out here, the second is the intermediate acting mechanism. It will take some hours, few hours, right? So minutes to hour it will take. That's why this is known as intermediate acting mechanism. And the third mechanism is a long-term mechanism. It takes few days. Okay, few days. Okay, 3 to 10 days at least required for this mechanism to operate fully. That's why this is known as long-term mechanism. Now, under this rapidly acting mechanism, you can find out that many important mechanisms are written. Baroreceptor reflex mechanism, the chemoreceptor reflex mechanism, CNS ischemic response, and epinephrine and norepinephrine secreted from adrenal medulla. Right? So all of them are under the rapidly acting mechanism. But question is, which one is the most rapidly acting mechanism? So obviously the baroreceptor followed by chemoreceptor. Okay, so this baroreceptor reflex mechanism is the most rapidly acting mechanism. Okay, within 5 to 8 seconds it start working. Okay, most rapidly acting mechanism is this baroreceptor mechanism, followed by this chemoreceptor reflex mechanism. Okay, then at the level of intermediate acting mechanism, you can find out that capillary fluid shift mechanism is there, stress relaxation and reverse stress relaxation, and third one is the renin angiotensin mediated vasoconstriction. So you have to be careful here. Renin angiotensin is causing vasoconstriction. That is a part of intermediate mechanism. It will start working within few hours, minutes to hours. But if you look at the renin angiotensin with aldosterone system, RAS aldosterone system, then it is a part of the long-term mechanism which require few days. So if I talk about angiotensin mediated vasoconstriction only, then it is a part of the intermediate mechanism. But if you think of renin angiotensin system is acting through aldosterone and other mechanism, then that is a part of the long-term mechanism. So under long-term, you can find out here the fluid conservation mechanism in the level of kidney, okay, by the hormone ADH, ANP and aldosterone. Okay, antidiuretic hormone, atrial natriuretic peptide, and aldosterone. They are part of the long-term mechanism, right? And renin-angiotensin system and aldosterone system, this is also part of the long-term mechanism. Now, looking at all of these mechanisms, sometimes they may ask you that which mechanism is the most potent for regulation of your blood pressure, most potent. Then your answer is the last one. This RAS aldosterone system is the most potent mechanism for blood pressure regulation, and the second most potent is this one. CNS ischemic response is the second most potent, okay, mechanism for regulation of our blood pressure. Getting my point? So please note down first that all these different types of mechanism. Now this long-term mechanism that we are mainly going to discuss with the renal system, because all this hormone, the mechanism of their action, everything that will be discussed in the renal system, right? Now coming to this intermediate acting mechanism, they are not very popular for your MCQ, but we will discuss a little bit. Okay, so first one, this capillary fluid shift mechanism. So what is that? This is very simple. If this is your capillary, okay, suppose the blood pressure of this person is very high. Okay, so if the blood pressure is high, I can easily understand that the hydrostatic pressure within this vessel wall, within this vessel, is also high, right? So more the hydrostatic pressure, what will happen? The fluid will move out of this capillary, because we know that movement of the fluid into out of the capillary is determined by a force that is known as the Stirling force. That is known as the Stirling force. We are going to learn the Stirling force at the kidney chapter. But for the time being, you remember that whenever the blood pressure is high, right, hydrostatic pressure within this capillary will also be higher. That will push some of the water out of this capillary. That means fluid is shifting out of this capillary. So if the fluid is shifting out of this capillary, what will happen to the pressure inside this capillary, inside this vessel? The pressure will reduce. So this is an way by which our blood pressure can be reduced by pushing some extra water out of this capillary. But obviously, if this fluid more is in the tissue space, then edema is going to form. But anyway, my pressure within this vessel will be lesser. So this mechanism is known as capillary fluid shifting mechanism. Now second, you look at stress relaxation of the vessel. Stress relaxation of the vessel. Stress relaxation of the vessel is basically a property of the smooth muscle which is present in the vessel, right? So suppose this is a blood vessel, and this blood vessel is under the high pressure, means the blood pressure inside this vessel wall is very high. So I can understand that the smooth muscle which are present in this vessel wall, these smooth muscles which are present in this vessel wall, they are under high tension, right? Now this smooth muscle has a property. Smooth muscle has a property that whenever you keep this smooth muscle under constant stress, it will relaxes, right? So whenever you are keeping this vessel wall under huge tension or huge stress, after certain point of time, after few hours, this vessel wall will be relaxes. So whenever this vessel wall is relaxed, now I can understand that the diameter of the vessel wall is a little bit increased. So what will happen to the blood pressure inside this vessel wall now? The blood pressure will be reduced because of this relaxation. So this is known as stress relaxation of the vessel. Under stress, the vessel is relaxing, and this is due to the relaxation of the smooth muscle which are present on the vessel wall. And if the blood pressure is low here, the reverse stress relaxation will occur. Means the smooth muscle will constrict a little bit, and that will causes decrease in diameter of the vessel wall. That is known as reverse stress relaxation, right? So these two mechanisms are important for your question, but I have not seen many MCQ from this region. Now the main thing that we have to read completely is this three: baroreceptor reflex mechanism, chemoreceptor reflex mechanism, and CNS ischemic response. How these three immediately acting mechanism, rapidly acting mechanism is controlling your blood pressure. So now we are starting with baroreceptor reflex. Okay. Right. So, baroreceptor reflex. Baroreceptor, and parallelly, we are also going to discuss the chemoreceptor. Chemoreceptor. Right. So, first question is, where this baroreceptor and chemoreceptor, where they are located, right? To understand this, I am drawing one diagram. So, suppose this is the common carotid artery. Then the common carotid artery is dividing into an internal carotid artery. So, this is the internal carotid artery and this is the external carotid artery, right? Schematic diagram. Okay. So, this is nothing but the internal carotid artery and this is the external carotid artery. Okay. Now I can find out that internal carotid artery, at the point of its origin, there is a little dilated portion. This dilated portion is known as sinus. Okay, this is known as carotid sinus. Carotid sinus. Right. So carotid sinus is nothing but it is a little dilated portion of the internal carotid artery. So it's a vessel. So if I look at the wall of this blood vessel, then at the level of this vessel wall, there are some nerve fiber ending. This nerve fiber ending can detect the stretch, can detect the mechanical stretch on this vessel, and this is known as the baroreceptor. So what I'm saying, just look at. Okay, so I'm saying that at the wall of this vessel, this carotid sinus wall contains some receptor. This receptor can detect the stretch, okay, or can detect the stretching of this sinus region, and this receptor are known as baroreceptor. So first location I can write down here, that where the baroreceptor is located. Number 1, carotid sinus wall. Carotid sinus wall, right? Similarly, if you look at the level of arch of aorta, so suppose this is the arch of aorta schematic diagram, right? Arch of aorta schematic diagram. The blood is coming from this side. Similar to the carotid sinus, the arch of aortic wall also contain few mechanoreceptor or stretch receptor on the vessel wall, and again this receptor are known as baroreceptor. That means I can say that carotid sinus wall, and the second location is aortic arch wall. In both of these location, the baroreceptor is present. Now in again and again I am saying it is located on the vessel wall, right? So if I ask you, wall means in which layer of the vessel wall, intima, media or externa? Remember, baroreceptor are always located in the adventitial layer of vessel wall, means external most layer it is located. Okay, so adventitial layer of blood vessels, this baroreceptor are located. Now second, I told you that baroreceptor, they are which type of receptor? They are mechanoreceptor. They are mechanoreceptor. What do you mean by that? Means they can detect the stretch. So they are basically stretch receptors, right? So this thing you also have to remember, that baroreceptor can detect the stretch. That's why this is known as mechanoreceptor. So due to any condition, if the vessel wall is getting stretched, when the vessel wall is going to be stretched? If the blood pressure is high. So suppose the blood pressure inside this carotid sinus is very, very high. So it is going to cause a stretching on this sinus wall and the baroreceptor will be activated. Similarly, if the blood pressure is high inside this arch of aorta, again the baroreceptor will be activated because of the stretching of the vessel wall. So that is the meaning of stretch receptor. That is the meaning of mechanoreceptor. Now, if you look at the nature of this receptor, they are mechanoreceptor. But what are they? Are they some kind of cells? Answer is no. Baroreceptor are basically a neuronal ending. End of neuron. Right? End of neuron. So, which neuron is supplying at the level of this carotid sinus? We all know that this area is supplied by this Glossopharyngeal nerve. So suppose this is my glossopharyngeal nerve, right? Okay, ninth cranial nerve. A branch of this glossopharyngeal nerve is going to supply the sinus region, and the terminal end of this branch will be divided into multiple parts, and this is nothing but my baroreceptor. So baroreceptor or mechanoreceptor, they are nothing but neuronal ending. Which neuron is located at the level of this carotid sinus wall? That is the ninth cranial nerve, but not the exact ninth cranial. There is a branch of ninth cranial nerve, and this branch of ninth cranial nerve is known as sinus nerve of Hering. This is known as sinus nerve of Hering, Hering. Getting my point? So this branch which is supplying this carotid sinus region, this is known as sinus nerve of Hering, right? So this is the nerve which is bringing sensation from carotid sinus baroreceptor. Now if I ask you, what about the aortic arch? Aortic arch baroreceptor, which neuron will supply? Obviously that aortic region baroreceptor will be supplied by nothing but the 10th cranial nerve or the vagus nerve, right? So now I can understand that the afferent from this baroreceptor, carotid sinus baroreceptor, the afferent is 9th cranial nerve, okay, and for aortic arch baroreceptor, the afferent is 10th cranial nerve, right? So this is the location of the baroreceptor. Now if I look at the chemoreceptor, so where they are located, okay, so where they are located, first of all, chemoreceptor I should write here. So look at the location. So at the area where this internal and external carotid artery is dividing, okay, at this area, look at the diagram. So this area, there is a small tissue. There is a small tissue here, small tissue. The shape of this tissue is just like a tennis racket or badminton racket, you can say. So this is just like a tennis racket shape, small tissue. This tissue is known as carotid body. One carotid body is there on the right side where the internal and external is dividing, and another carotid body is there on the left side where internal and external is dividing. Similarly, at the level of this arch of aorta, there are bodies also. These are known as the aortic bodies. So this green color structure, tennis racket shaped structure that you are finding out here, this is nothing but a small tissue which is nothing but aortic body. So this is known as aortic body, right? Aortic body, right? Okay. So I can find out that aortic body, their number is 2 to 3 in number, but carotid body is only one on right side, one on left side. Okay, but aortic body is number and 2 to 3. Now, within these bodies, okay, so if I look at this carotid or aortic body, this is a very small tissue. Okay, it is said that the diameter of this small tissue is only 2 millimeter, and weight of this small tissue is 13 milligram. But if you look at the blood flow, then it is very, very enormous. Okay, could you recall the blood flow of the other tissue? Okay, you will learn that in regional circulation chapter, okay, later on. But look at the blood flow at the level of this carotid body or aortic body is 2000 ml per 100 gram of tissue per minute. Getting my point? So this blood flow is so enormous. This is very, very higher than any of the organ system in our body. And this blood flow is so enormous that the survival of this carotid body or aortic body is based on only dissolved oxygen. What I'm saying? You know, blood contains 2 types of oxygen, arterial blood or venous blood, that is hemoglobin bound oxygen and dissolved oxygen. You will read in respiratory system. Now, most of the tissue require the hemoglobin bound oxygen because hemoglobin bound oxygen amount is maximum. But in case of this carotid body and aortic body, blood flow is so huge that even if it is taking the dissolved oxygen also, that is adequate for survival. Although the dissolved oxygen amount is very less, but blood flow is high. So even if the dissolved oxygen quantity is very less, but still it can survive only based on this dissolved oxygen. This has applied importance you will learn in hypoxia chapter in respiratory system, right? Now, inside this carotid body and aortic body, there is a special type of cell. This cell is known as glomus cell type 1. Glomus cell type 1. This glomus cell type 1 is actually the chemoreceptor of your body. Getting my point? So this glomus cell type 1, which is present inside this carotid body and aortic body, they are actually the chemoreceptor of your body. Getting my point? So now if I write down here that where the chemoreceptor is located, so chemoreceptors, where they are located, your answer will be that, sir, this is nothing but glomus cell, but where they are located? Carotid body, and it is also located inside aortic bodies, right? So inside carotid bodies and inside aortic bodies, these chemoreceptors are located. Now, chemoreceptor means that will be stimulated by chemical. So like for example, if I ask you how the baroreceptor is activated, I told you baroreceptor are mechanoreceptors. So whenever there is stretch, whenever there is increased blood pressure, baroreceptor will be activated. Now if I ask you chemoreceptor, how the chemoreceptor is going to be activated, it will be activated by chemical signal. Never forget that the three stimulus for chemoreceptor is decreased partial pressure of oxygen, that is hypoxia of the arterial blood, increased partial pressure of carbon dioxide, hypercapnia, and increased H plus ion at the level of arterial blood, that is acidosis. So hypoxia, hypercapnia, and acidosis, these three are the stimulus for chemoreceptor. So you must be thinking, so how this chemoreceptor is going to regulate my blood pressure, because it is not even stimulated by blood pressure, right? That we are going to understand, right? But now look at the afferent neuron supply. If I look at the afferent neuron supply to this chemoreceptor, it is similar to the baroreceptor because it is located in the same area, na? So the same vagus which is supplying this aortic arch baroreceptor, the same vagus is going to supply the chemoreceptor also. The same sinus nerve of pharynx, which is supplying this baroreceptor, the same nerve is also going to supply the chemoreceptor, right? So the sinus nerve of pharynx at the level of carotid region and the vagus neuron at the level of aortic region are the afferent for this chemoreceptor also, right? Now afferent will bring the sensation from this periphery to the center in CNS. So if I ask you what is the center of both of this chemoreceptor and baroreceptor is located, center of both of this baroreceptor and chemoreceptor is located at the level of medulla. And from medulla, the efferent through which this baro and chemoreceptor is going to act, that is nothing but your sympathetic system as well as your parasympathetic system, right? Parasympathetic system. So getting my point? So now we can understand that both of them are known as reflex. Baroreceptor reflex, chemoreceptor reflex. Reflex means there should be a receptor, that is baroreceptor, chemoreceptor. There should be an afferent from the receptor, that is 9th and 10th cranial nerve. There should be a center, that is at the level of medulla, and there should be an efferent, that is nothing but your sympathetic and parasympathetic system. Now we are going to look at how this baroreceptor reflex is going to act and applied aspect of this baroreceptor reflex, right? Very, very important for your MCQ. Okay. So I told you that baroreceptor are mechanoreceptor. So due to any reason, if your blood pressure is high due to any reason, suppose suddenly your blood pressure is high due to any reason, due to anxiety, due to stress, anything. Whenever your blood pressure is high, we have just discussed that it is going to cause a stretch on this vessel wall and it will cause activation of the baroreceptors. Baroreceptors are active. Now obvious question is, BP high means how much higher of blood pressure you require, sir? Means if the blood pressure is lower, baroreceptor will be inactivated. How much lowering of blood pressure is required to inactivate the baroreceptor completely? There is one thing which is known as working range. So please remember, The working range of this baroreceptor is from 50 millimeter of mercury up to 200 millimeter of mercury. Means if the blood pressure is below 50 millimeter of mercury, baroreceptor will be completely inactivated. If it is more than 200 millimeter of mercury, further activation, more activation of baroreceptor is not possible. What I am saying, you may not understand. So if I draw this curve, you will be understand this in a better way. So x-axis is the blood pressure and y-axis is the activation of this baroreceptor. Activation, okay, of baroreceptor. Baroreceptor activation follow a curve like this. Okay, so in this curve, this is 50 and this is 200. So I can understand that if my blood pressure is changing from this 50 millimeter of mercury towards 200 millimeter of mercury, baroreceptor is going to be activated more and more. But whenever your blood pressure is more than 200 millimeter of mercury, the response is plateau, means no further activation of baroreceptor is possible. If the blood pressure is below 50 millimeter of mercury, baroreceptor is almost or completely inactivated. This is the meaning of baroreceptor activation curve. The person who suffers from chronic hypertension, suppose I am a person, I am suffering from chronic hypertension, my normal blood pressure is very high. So, how this baroreceptor will modify itself to respond in this chronic high blood pressure? There is one phenomenon which is known as right shifting of this baroreceptor curve, which is known as resetting of baroreceptor curve. Resetting means the baroreceptor curve is shifting on the right side. What is the meaning of that? Meaning of that, now the working range of this resetting curve, resetted curve, is very higher than that of the previous working range. So previous working range was here 50 to 200. Now the working range it's set to a higher level, and this setting is known as the resetting of baroreceptor functions curve, right? So here we were plotting the baroreceptor activation with response to blood pressure. If I ask you, which blood pressure you are talking about, sir? This 50, 200 you are talking now. This is which blood pressure? Systolic blood pressure you are talking? No. This is the mean blood pressure I am talking about, right? So baroreceptor respond to mean blood pressure also. It also respond to pulse pressure also. But it is most sensitive to, please note down, baroreceptor is most sensitive to pulse pressure greater than mean arterial pressure. Getting my point? So this is clearly written in Genong. I have a cutout from Genong. I will show you later on. But for the timing, believe me, that baroreceptor is most sensitive to pulse pressure, although it also responds in mean pressure. So whenever your blood pressure is high, this blood pressure high means it may be higher pulse pressure or it may be higher mean pressure. The baroreceptor is going to be activated, right? We had started our discussion from here. Now if the baroreceptor is activated, we have already seen that the afferent neuron from this baroreceptor will bring the sensation to the level of center, that is medulla. Which center of medulla? The center at the level of medulla, where this afferent, that is 9th and 10th cranial nerve, will bring the sensation, is nothing but known as nucleus tractus solitarius. All of you know this name from your anatomical knowledge. So this is nucleus tractus solitarius. So if the baroreceptor is active, this NTS will also be activated. Now from this NTS, the signal will go to two other area of medulla. That is, one is CVLM. Okay, CVLM, C stands for caudal. Okay, so CVLM, where should I write? I should write here. C stands for CAUDL, caudal ventrolateral medulla. Okay, so this is known as caudal ventrolateral medullary region, CVLM, right? So when NTS is active, this CVLM will also be activated. Parallelly, the signal will also go to another area, that is nothing but CIC. CIC stands for cardiac inhibitory center, cardiac inhibitory center, cardio inhibitory center, cardiac inhibitory center. You know the cardiac inhibitory center, heart is inhibited by vagus neuron. So this center is also known as cardiovagal center. Okay, cardiovagal center or cardio inhibitory center. So this center will also be stimulated, right? So whenever your NTS is stimulated, CVLM and CIC both are stimulated. Now, you know, whenever I am saying this stimulation means this is nothing but the neuron which is extending from this NTS to CVLM, that neuron is secreting excitatory neurotransmitter, right? So this stimulation means there is release of excitatory neurotransmitter here, and that is nothing but glutamate. That is nothing but glutamate, okay? Right. Now, the neuron which are located at the level of CVLM, they are inhibitory neuron. So neuron which will be projecting from the CVLM up to RVLM. So this RVLM center is very important. So what will be the full form? R is nothing but rostral. Okay, so simple: rostral, ventral, lateral, medulla. Rostral, ventral, lateral, medulla, RVLM, which is also known as vasomotor center, which is also known as vasomotor center. Just hold on, I will make this diagram more beautiful. Okay, so this is RVLM, which is also known as vasomotor center or VMC. Please note down, this RVLM is also known as vasomotor center. Vasomotor center was the old name. Now it is known as the RVLM or rostroventro-lateral medulla. So I told you the neuron which is projecting from the CVLM to RVLM, they are inhibitory neuron. So obviously, if the CVLM is stimulated, RVLM is going to be inhibited, right? And this RVLM, what is the importance of this center? This is the center which is connected at the level of spinal cord, which is connected at the level of spinal cord. Which segment of the spinal cord? The thoracolumbar region of the spinal cord, and specifically which region of the spinal cord? The intermediate gray column of the spinal cord. We all know that this area of the spinal cord, that is the thoracolumbar region of the spinal cord, the intermediate IML gray column, they are the area which give rise to sympathetic system. Sympathetic system. Getting my point? So basically now I can understand that NTS is connected with CVLM, CVLM is connected with RVLM, RVLM is connected with spinal cord, and that spinal cord is giving rise to sympathetic system, thoracolumbar division, right? So if I stimulate NTS, CVLM is stimulated. If CVLM is stimulated, then this RVLM is inhibited. That is the most important point you have to note down here. So whenever your baroreceptor is activated due to any reason, I told you when the baroreceptor will be activated if it is stretch. When the stretch will occur if the BP is high. So now you think of this scenario. Your BP is suddenly high. Suppose suddenly I get anxious. My blood pressure will shoot out. Whenever blood pressure will shoot out, this carotid sinus baroreceptor, they are very sensitive. They will be immediately activated within few seconds. Whenever that is activated, the signal will goes to the level of this NTS. NTS will be activated, CVLM will be activated, but that CVLM is going to inhibit the RVLM, and RVLM is directly related with the sympathetic system. So if your RVLM is inhibited, your sympathetic system will also be inhibited. That means I can understand the sympathetic system will go down. If the sympathetic system is going down, we know that the stroke volume will go down, okay, and the cardiac output will also go down, and the blood pressure is going to be normalized once again. Getting my point? Same way, if you look at this center, other center, the CIC, okay, this center, the CIC or cardiovagal center, this is the center from where the parasympathetic system originate. So this is parasympathetic system, right? So whenever your NTS is active, your CIC, that is this parasympathetic system, will be activated. Parasympathetic system activated means what will happen? It will reduce the heart rate of the person also, and that heart rate will also contribute to the reduction in blood pressure. Getting my point? So now you look at the whole diagram. What is happening? So whenever your baroreceptor is activated due to high blood pressure, this whole reflex mechanism is bringing down the sympathetic system and it is stimulating the parasympathetic system. By this inhibition of sympathetic and stimulation of parasympathetic, your blood pressure is normalized again. Getting my point? So this is a reflex pathway. Now you can see where is the center. Center is here. These three center, they are located at the level of medulla, and this sympathetic system and this parasympathetic system, they are nothing but the efferent of this reflex pathway. Okay, so now if I summarize this whole thing, what I told you already, okay, so this is the summary. Whenever your BP is high due to any reason, it is stimulating the baroreceptor. Baroreceptor stimulation means there will be inhibition of vasomotor center, that is the RVLM, and there will be stimulation of CIC, cardiac inhibitory center or parasympathetic center. Vasomotor center inhibited means my sympathetic system will go down, and CIC stimulated means my parasympathetic system will go up, and combination of these two is again going to normalize the BP normalization, right? So this is the pathway by which baroreceptor is constantly monitoring your blood pressure. Whenever it is suddenly shooting out, it is trying to depress. Whenever a blood pressure is shooting out, baroreceptor is constantly trying to depress it. Okay, now if I ask you that if the opposite thing is happening, then what will happen? So suppose now BP is suddenly low, okay, due to blood loss or any condition. Suppose the BP is suddenly low. So I can understand, I told you already, the working range of blood pressure of baroreceptor is from 50 to 200. Some books are saying different values, 70 to 170. Anyway, this is from Guyton. Okay, so if the BP is low, so what will happen? The baroreceptor will be inhibited, or I can say the baroreceptor activation will decrease. Completely inhibition require very low blood pressure. But whenever your blood pressure is reducing gradually, activation of baroreceptor will also decrease gradually by this curve that we have plotted already. Okay, the sigmoid separate curve, right? So if the baroreceptor is inhibited, then again you look at this flowchart. Okay, if the baroreceptor is inhibited, then NTS is not going to be activated. If NTS is not going to be activated, CVLM is not going to be activated. If CVLM is not activated, then RVLM will not be inhibited, right? Okay, so if the RVLM is not inhibited, what is going to happen to RVLM? Remember, this RVLM is a tonically active center. Well, please remember, this is very important. So this is tonically active center. What do you mean by tonically active? Tonically active center means the center is always active until and unless you inhibit it by someone. So who is inhibiting this RVLM? CVLM. They inhibit the RVLM. But if you don't inhibit, if you cut out all the inhibition, the center has a power so that it will be activated automatically, right? That is known as a tonically active. Tonically active means the center is always active. The center is active even when you are sleeping. This has been asked in AIIMS entrance examination, that what will happen to the discharge pattern of RVLM? It will remain active although your brain is sleeping, but RVLM is active. It will maintain the vessel tone by activating the sympathetic system even during your sleep period, right? So whenever your BP is low, baroreceptor is inhibited. In this condition, no one is activating this NTS. But if no one is activating the NTS, CVLM will also not be activated. But what will happen to VMC, vasomotor center, or RVLM? It will be activated because it is a tonically active center, right? And whenever the VMC is activated, we know that it is going to stimulate your sympathetic system, and if your sympathetic system is activated, your stroke volume will be higher, your heart rate will also be higher, and that will increase your blood pressure. So this way, whenever your blood pressure is low, baroreceptor is not doing anything. Baroreceptor is inactivated, but that inactivation of the baroreceptor is activating the RVLM, activating the VNC, and that's why your blood pressure is rising. So getting my point? So if your blood pressure is high, then the baroreceptor is bringing down the blood pressure. That is the active role of baroreceptor, that if your blood pressure is high, baro will try to bring it down. But if your blood pressure is down due to certain causes, baroreceptor is not going to make it higher. Okay, who is making this blood pressure higher? That is the RVLM. Why? Because RVLM is a tonically active center. So whenever your blood pressure is down due to any reason, baroreceptor is simply inactivated. And if it is inactivated, RVLM is going to take the job, and that will try to increase your blood pressure, right? I hope all of you have understood this phenomena. Now, with the help of this baroreceptor concept, we have to discuss many applied aspects of this baroreceptor functioning. First applied aspect is change of posture. Change of posture. How the baroreceptor is going to manage change of posture. So, suppose you are lying on a supine posture and suddenly you are sitting up, right? So supine to sitting up or standing position. So I'm writing here from supine position to standing position. All of you know this thing, that what is going to happen. So whenever you are in supine position, suddenly you are in standing position, due to effect of gravity, most of the blood, not most of the blood, approximate 500 ml of blood will be pulled to the lower part of the body. Okay, because the veins has huge capacities to store blood, most of the blood will be pulled to the lower part of the body. So I am writing here that because of this sudden change of posture, there will be pulling of blood, okay, at lower part of the body, lower part of body. Okay, how much blood? I told you that approximate 500 ml of blood is going to be pulled in the lower part of the body, mainly in the level of thigh and leg region and the abdominal vein region. But if there is pulling of extra blood in the lower part of the body, so heart chambers are going to get less blood. So what will happen to the venous return to the heart? Venous return decreases. Decrease in venous return means we all know that venous return is a determinant of preload or end diastolic volume. So end diastolic volume decrease means there will be decrease in stroke volume. Decrease in stroke volume means there will be decrease in cardiac output. Decrease in cardiac output means the net result is that there will be decrease in blood pressure. Okay, there will be decrease in blood pressure, right? So whenever you are changing this posture from supine to standing, your blood pressure is decreased. Now you tell me, if your blood pressure is decreased, what will happen? Which system is going to correct this sudden decrease in blood pressure? Obviously, the most rapid control system, that is the baroreceptor. So now this will activate or inhibit the baroreceptor. This is going to be inhibit the baroreceptor, because baroreceptor will be active in high blood pressure, not in the low blood pressure. So whenever blood pressure is decreasing, the baroreceptor will be less active, or I am writing here the baroreceptor is getting inactive. Now just now we have discussed, if the baroreceptor is inactive, this is going to activate the vasomotor center indirectly, or you can say the vasomotor center or VMC will be activated because of the tonic nature, because of the tonic nature of this center, right? So whenever your vasomotor center is active, we know that it is going to activate your sympathetic system. Sympathetic system activation means it is going to increase the force of contractility. So what will happen? The force of contraction will be high. Force of contraction high means there will be increase in stroke volume, and this stroke volume is going to correct this fall of stroke volume and cardiac output. Not only that, sympathetic system is going to increase the heart rate of the person also. So the multiplication product of this heart rate and the stroke volume, heart rate and stroke volume, they are going to increase the cardiac output. Not only that, the sympathetic system is also going to causes vasoconstriction. So if there is vasoconstriction, what will happen to the TPR or total peripheral resistance? It is going to be high. Increase TPR, total peripheral resistance, will be high. And vasoconstriction means there will be constriction of the arterioles system also as well as venous system. So if you compress the vein, the extra blood which was pulled in the venous system, that will be pushed toward the heart. So what will happen? This is going to increase the venous return also. And by this all means that increase in contraction, right? Increase in stroke volume, increase in heart rate, increase in venous return. By all this means the blood pressure which was decreased already, that blood pressure will be corrected soon, right? So if you try to understand this change of posture and blood pressure correction with the help of a graph, then the graph will look like this. Okay, look at, very important. So x-axis is the time axis and y-axis is the mean arterial pressure of the person, right? So suppose the mean arterial pressure is here at 100 millimeter of mercury. Okay, it was normal, 100 millimeter of mercury, normal. Suddenly the person is changing the posture. So this is the part where there is sudden change of posture, right? What is going to happen? This blood pressure will suddenly fall to a low value. Normally, this fall of mean pressure is around 5 to 10 millimeter of mercury only, not more than that. Okay. Now, whenever there is fall of this blood pressure, within this 5 to 8 seconds, the baroreceptor will be inhibited. Inhibition of the baroreceptor means compensatory sympathetic system will be activated. That will drag down the blood pressure to a very high level. So this is, okay, increase in blood pressure. But look at, the immediate sympathetic system activation is not correcting the blood pressure to the normal level immediately. First it will overcorrect, blood pressure will overshoot. Then whenever the blood pressure is overshoot, at this point again the baroreceptor will be activated. It will try to bring the blood pressure again to the downward direction, right? Again the blood pressure will be inhibited. Again it will try to raise the blood pressure. Now you look at, this fluctuation is decreasing gradually and now ultimately it will be stabilized. The total time for complete stabilization require approximate 1 minute time period. Getting my point? But baroreceptor inhibited, or action of the baroreceptor is starting within few seconds, 5 to 8 seconds, right? And then it is overcorrecting, then undercorrect, overcorrect, undercorrect. This fluctuation will continue and then the blood pressure will be stabilized within minutes. So this way, whenever you change your posture, okay, from sitting to standing, from standing to supine, your blood pressure is corrected by the baroreceptor within few minutes, right? Now you know that if your sympathetic system or parasympathetic system is disturbed, autonomic failure, right? Suppose one person is suffering from diabetic neuropathy, right? Or in some cases of Parkinsonism disease, there is autonomic failure. So whenever there is autonomic failure, right, what will happen? This correction of blood pressure, okay, this correction after baroreceptor inhibition is not going to happen. And in that cases, this fall of blood pressure during this change of posture, from supine to standing will be very higher than normal, and that will persist for long duration because the sympathetic limb and the parasympathetic limb is not working properly. By definition, if the fall of blood pressure from supine to standing is greater than 20 millimeter of mercury for systolic blood pressure, or diastolic blood pressure is falling greater than 10 millimeter of mercury, if this much fall is occurring within 3 minutes of standing, okay, so you're in a supine position. Generally the patient is kept supine for 5 minutes and then suddenly he is asked to stand up. So during this standing, if the blood pressure is falling, systolic blood pressure greater than 20 or diastolic blood pressure more than 10 millimeter of mercury, then the person is labeled at that he is suffering from orthostatic hypotension, or the person is suffering from postural hypotension. Okay, so postural hypotension or orthostatic hypotension. Generally this falls should occur within 3 minutes. If it is happening after 3 minutes, then that is not orthostatic hypotension. There may be other cause, maybe blood loss, maybe volume loss, this kind of cause may occur. But most of the cases, if the autonomic failure is there, then blood pressure fall, this severe blood pressure fall, and that will remain for long duration. Sustained severe fall will occur within 3 minutes of standing, right? So this is the postural correction of blood pressure by baroreceptor and orthostatic hypotension. Now, second applied aspect of this baroreceptor is carotid sinus massaging. Carotid sinus massaging, right? You must be thinking that carotid sinus massaging, where I have read about this, right? Sometimes this carotid sinus massaging is done for emergency treatment of PSVT, paroxysmal supraventricular tachycardia, right? So why that is done, right? So in physiology, they have already asked you question regarding this carotid sinus massaging. The MCQ was that if you do massaging on carotid sinus, what will happen to the total peripheral resistance? Examiner are very sensitive about this total peripheral resistance, right? So this is the sinus region that I have made here. Okay, I am massaging here. So massaging means basically I am giving some external pressure. That's all. So I am giving some external pressure. Okay, if you do massaging like this at this region of this carotid sinus, that is external pressure you are applying on carotid sinus region. So what will happen to the pressure inside this sinus? This is the only thing you have to think, right? So there will be increase in pressure inside the sinus. Sinus pressure is high. So I can write down this will leads to increase in sinus pressure. Which receptor is there at the level of this sinus? Baroreceptor. So what is going to happen? They will be activated or inhibited. Baroreceptor will be activated, positive. Baroreceptor activation means what is the effect of this activation? Vasomotor center will be inhibited and cardio-inhibitory center will be stimulated. Vasomotor center inhibited means sympathetic inhibited. Sympathetic inhibited means contractility will decrease. That's why the stroke volume will decrease, right? And vascular constriction will not be there. There will be vasodilatation. So what will happen to the TPR? TPR will fall. Please remember, sympathetic and parasympathetic. Sympathetic has main effect on contractility of the heart because sympathetic system supply the ventricular muscle mainly rather than the SA node, AV node or atrial muscles. On the other hand, parasympathetic mainly supply the SA node, AV node region. That's why parasympathetic is mainly for the control of the SA node, AV node, means heart rate will be controlled. Conduction velocity through the AV node will be controlled by parasympathetic. But sympathetic main supply at the level of ventricular muscle. Ventricle is responsible for force generation during contraction. That's why I am writing sympathetic system inhibition means stroke volume will be decreased and vasodilatation will be there, because of which TPR is going to be reduced. Parasympathetic stimulation means we know that heart rate is going to be reduced and the conduction velocity of impulses through the AV node will also decrease, right? This decrease in conduction velocity through the AV node is very, very beneficial, and that is utilized for the emergency treatment of PSVT. Because you know that PSVT means paroxysmal supraventricular tachycardia. So someone is producing huge amount of heart rate, someone is producing tachycardia above the ventricle region. Okay, that's why supraventricular tachycardia. So if all this higher rate, if all this heartbeat is entering at the level of ventricle, high rate, suppose 300, 400, if all these beats is entering at the level of ventricle, then ventricle will also start beating with higher rate. And that is dangerous. Why? If ventricular rate is very, very high, then it will not get time for proper filling. Diastolic duration will be severely reduced. And if the proper filling is not there, then stroke volume will be decreased and the brain is going to suffer from hypoxia. That's why the emergency treatment is to control the ventricular rate first. Okay, whatever may be my atrial rate, okay, atrium is contracting with higher heart rate, that will not affect the ventricular filling much. Why, you know? Because ventricular filling is done mainly passively. Active contraction of atrium contribute to only 25% of the ventricular filling. So forget about that 25% filling. Even if the remaining filling is occurring, then there will be not much problem. So my main target is to control the ventricular rate. How to control? You block some of the conduction. You block some of the heart rate at the level of AV node. How to block? You reduce the AV nodal conduction, and that is done by massaging the both carotid sinus, which will block some of the impulses, so ventricular rate will be normal, and that will maintain the perfusion to the brain and other vital organ. That is the emergency treatment of PSVT, right? So this is the beauty of carotid sinus massaging. This carotid sinus massaging, okay, can be given as a direct MCQ. This carotid sinus massaging can also be given as an applied MCQ. How? Massaging of carotid sinus is also the diagnostic of one disease which is known as carotid sinus hypersensitivity syndrome. Okay, you must have heard this. Carotid sinus hypersensitivity syndrome. Hypersensitivity syndrome, right? So what is going to happen in this syndrome? Carotid sinus is hypersensitive, means the baroreceptor which are located at the level of sinus is very hypersensitive. That means even if you give a little compression, even if you give a little pressure on this carotid sinus region, this is going to happen. Stroke volume will be decreased, means blood pressure will be severely low. Okay, the total peripheral resistance will severely decrease, your heart rate will decrease, and the person may fall on the ground, the person may become unconscious suddenly. And before unconscious, there will be a blackout. This is in patient who is suffering from carotid sinus hypersensitivity syndrome due to any pressure at the level of neck region, maybe tight collar of this shirt. There may be, suppose one tie has put in this neck region. Suppose he is stretching his neck like this. So little amount of stretching can lead to this kind of symptoms: hypotension, decreased heart rate, and fall on the ground, unconsciousness. That is known as carotid sinus hypersensitivity syndrome. That can be diagnosed by giving little massage at the level of carotid sinus and looking at your blood pressure and heart rate. So this is the applied aspect of this carotid sinus massaging. Now, apart from this clinical and applied aspect, sometimes some experimental question can also be given regarding this carotid sinus and its applied part, right? So suppose this is again the same diagram, carotid sinus. The experimental question will be given like this, that if you give ligature, okay, at the level of this carotid sinus, and this is known as the proximal ligation of the carotid sinus, means before the origin of the carotid sinus, you have given a ligature, right? So what will happen? I have to just think that in these cases, what is going to happen to the pressure at the level of sinus? Very simple. If you are blocking here, so blood flow will not be there at the level of this sinus region. So sinus pressure will reduce. Sinus pressure decreases. Decrease in sinus pressure means we have already seen that baroreceptor will be inhibited. Baroreceptor inhibited means vasomotor center will be activated. Vasomotor center activated means your blood pressure will be high, your heart rate will be high. This was the question which has been asked in AIIMS entrance examination. In the next year, okay, they asked a different question, and student thought that this is a repeat question. No, they asked that if you ligate both the carotid sinus and the ligature is placed, okay, distal to the carotid sinus. So this is the distal ligature, okay, distal to the sinus. So what will happen in these cases? This proximal part is open, so blood flow is maintained, but that blood is not able to go through this ligature region. So what will happen? More and more blood in this region means more and more blood pressure. That means I can understand that the sinus pressure will be high in this condition. Sinus pressure will be high in this condition. Sinus pressure higher means baroreceptor is going to be stimulated. Baroreceptor stimulated means vasomotor center will be inhibited. That means the blood pressure will fall as well as the heart rate will also fall. So just opposite effect you are seeing in this condition. So this is the experimental question related to this baroreceptor and carotid sinus region, right? I hope you got it. So this is all about how the baroreceptor is controlling our blood pressure from time to time, okay? So now we look at, we have discussed many things. Okay, before going to the next discussion, I am going to show you this genome. Okay, so here I told you that baroreceptor is most sensitive to pulse pressure. Where it is written? Genome. Okay, it is written that this receptor are most sensitive to change in pulse pressure but also respond to change in mean arterial pressure. Which receptor? Carotid sinus and aortic arch depressor or baroreceptor, right? So they are most sensitive to pulse pressure. Never forget this. Okay, and you look at here this diagram which I have taken from book. Okay, so in this diagram, if I zoom it out here, you are finding out certain neuronal ending here. See, these are the neuronal ending, light bluish color. This neuronal ending is coming from this glossopharyngeal nerve, but branch of glossopharyngeal nerve that is known as sinus nerve of hearing, right? And you can also find out another structure here. Could you find out this structure here? Yes, this is nothing but your carotid body. Inside this body there will be glue muscle, and that glue muscle is the chemoreceptor, right? Similarly, if you look at the arch of aorta here, okay, so you are again finding out multiple this neuronal ending. This is nothing but aortic arch baroreceptor, and in between you are finding out these bodies. Look at here, this white color bodies. So this is nothing but aortic bodies. They are nothing but our chemoreceptor. Okay, so now we have understood that how the baroreceptor is functioning. Now our next understanding is how the chemoreceptor is controlling our blood pressure. Because previously I told you that chemoreceptor, they are activated by which chemicals changes in the blood? Decreased partial pressure of oxygen, hypoxia, hypercapnia, acidosis, right? But if your blood pressure is very, very low, suppose it is lower than 70 millimeter of mercury, blood pressure is very, very low and it is lower than 70 millimeter of mercury, right? Then what will happen to the perfusion at the level of carotid body, aortic body? Look at the perfusion. So I told you this carotid body and aortic body, they contain a cell, glomus cell, which can detect the hypoxia, hypercapnia, acidosis. Now there is a fourth one, that is decreased blood pressure. Decreased blood pressure means perfusion or the blood flow which is occurring at the level of this carotid body, aortic body, that is reduced. So obviously there will be creation of local hypoxia surrounding this glomus cell. There will be creation of the local hypercapnia surrounding this glomus cell. This local hypoxia and local hypercapnia is going to stimulate the chemoreceptor in this scenario. Getting my point? That's why I'm talking here that blood pressure should be very low. Very low means what is the range? Range is it should be below 70 millimeter of mercury. Then and then only the local hypoxia, the local hypercapnia will be created surrounding the glomus cell, and that will activate the chemoreceptor. So blood pressure can also activate chemoreceptor indirectly. Now if my chemoreceptor is active, okay, what is going to happen? Chemoreceptor is active. What is going to happen? Look at it is going to stimulate your vasomotor center. It is going to stimulate your vasomotor center by direct innervation. So if your vasomotor center is stimulated, I told you that your sympathetic system will be stimulated, okay, and your blood pressure is going to be higher. So chemoreceptor stimulation means blood pressure will be higher. Now what is the effect of chemoreceptor stimulation on CIC? It will also stimulate CIC. We have seen if the baroreceptor is active, VMC will be inhibited, CIC will be stimulated, but here both are stimulated, right? Now, if the CIC is stimulated, the parasympathetic is stimulated. What is the main effect of parasympathetic stimulation? Decrease in heart rate. So I can understand that this will try to decrease the heart rate. Means chemoreceptor stimulation means blood pressure will be higher but heart rate will be lower. But hold on, this is not complete, because if it is complete then you will be very, very confused. Why? Because just now I told you chemoreceptor is stimulated when the BP is lesser than 70 millimeter of mercury. If the BP is less than 70 millimeter of mercury, do you think your bradycardia is going to happen? Answer is no. So what is the other thing that you have to remember here? What is the main effect of chemoreceptor stimulation? Or I am putting the question in a different way. Baroreceptor is there in your body for controlling your blood pressure, exclusively controlling your blood pressure. Although it has little effect on your respiration, it will also inhibit the respiration. Baroreceptor main effect on BP, but it also inhibit ventilation, respiration a little. Secondary effect. What is the main effect of chemoreceptor? The main effect of chemoreceptor stimulation is stimulation of ventilation, stimulation of your respiratory center. Getting my point? So, the main effect of chemoreceptor stimulation is stimulation of your ventilation. So, the patient will start hyperventilating, hyperventilation, right? So, this part, at chemoreceptor, hyperventilation, these related things we are going to discuss in respiratory physiology, respiratory regulation. Okay, that's why if the person is suffering from hypoxia, okay, what will happen? The person will start hyperventilating. So that is the main effect of chemoreceptor stimulation, because chemoreceptor is stimulated by hypoxia, right? But whenever there is hyperventilation, okay, lung is expanding, recoiling with a high level. Hyperventilation causes stimulation of stretch receptor of the lung. It causes stimulation of stretch receptors of lungs, right? So details of this stretch receptor will be discussed in respiratory regulation again, but just for the timing, remember, stretch receptor of the lung are located at the level of bronchi and bronchial smooth muscles, right? Whenever your bronchus and bronchi is dilating to a high level, like for this hyperventilation, so person is doing hyperventilation, your bronchus and bronchus is dilated more and more. That will activate the stretch receptor of the lung. Remember, when the stretch receptor of the lung is activated, stretch receptor has inhibitory effect on this cardiac inhibitory center or parasympathetic center. So whenever you inhibit this CIC, what will happen to your heart rate? Now the heart rate is going to be increased. So now it become a little bit confusing. Confusing means by this direct pathway, so this is direct pathway. If you stimulate the chemoreceptor has direct effect on CIC. By this direct pathway, there is bradycardia. But whenever chemoreceptor is activating your ventilation, this is the indirect pathway for CIC. Whenever this indirect pathway is activated, via this indirect pathway, there is tachycardia. So, which effect the body is going to choose? Bradycardia or tachycardia, right? So, to understand that, you have to remember that if the chemoreceptor stimulation is mild, suppose there is mild hypoxia, then the direct pathway is going to dominate over the indirect pathway. And what is the net result? The net result is bradycardia. But whenever this chemoreceptor is stimulated by severe stimulation of chemoreceptor by severe hypoxia or acidosis, then the indirect pathway means increased ventilation will dominate, and indirect pathway means there will be tachycardia. That's why remember, if your chemoreceptor is activated, the effect on blood pressure is always the same, that is increase in blood pressure if your chemoreceptor is stimulated. So if you are suffering from hypoxia, okay, or hypercapnia, your blood pressure will be high. That is direct effect of chemoreceptor. But what will happen to the heart rate? It may be bradycardia, it may be tachycardia. That depends on how much activation you are doing at the level of chemoreceptor. Mild activation means bradycardia. Severe activation means moderate to severe activation means tachycardia is going to happen. Now we look at, there is an MCQ in AIIMS entrance examination where they asked that hypoxic induced tachycardia is due to which receptor? This was the question in AIIMS PG. Hypoxic tachycardia, okay, is due to which receptor? Baroreceptor, chemoreceptor, lung stretch receptor. What will be your answer? During hypoxia, if you are getting tachycardia, that is the indirect pathway. Indirect pathway, who is doing this tachycardia? That is nothing but stretch receptor of the lung. So this is induced by stretch receptor of the lung. Getting my point? So that's a very peculiar question and peculiar answer. Okay, that hypoxic induced tachycardia is due to stretch receptor of the lung. Right? Now you got it. So now you know how the baroreceptor is controlling our blood pressure, how the chemoreceptor is controlling our blood pressure. For the chemoreceptor to be activated, the blood pressure should be greater than 70 millimeter of mercury. Okay. Now think of a scenario that when the blood pressure is more lower, even below the 70 millimeter of mercury also, right? So suppose one condition where the blood pressure is greater than 50 millimeter of mercury, right? Now it is going to activate the third mechanism, barochemo done. Now the third rapidly acting mechanism, which was that is a CNS ischemic mechanism. So now we are going to discuss this third mechanism, that is CNS ischemic mechanism, CNS ischemic response. Okay, response or CIR, CNS ischemic response, right? So whenever your blood pressure is very low, okay, there will be hypoxia to the different parts of the tissue. Okay, so it is going to cause hypoxia. So whenever your BP is below 50 millimeter of mercury, it is going to cause severe hypoxia. Means all organ will suffer from hypoxia. Not only that, your brain will also be hypoxic. So I can write down here that it will also produce hypoxia at the level of brain also. Now remember, forget about other part of the brain. This vasomotor center or the rostroventrolateral medulla, they are very sensitive to local hypoxia and hypercapnia. So if your blood pressure is very low, there will be hypoxia at the level of brain, there will be lesser blood flow at the level of brain, and in this hypoxia, the vasomotor center is very sensitive. This vasomotor center will be strongly activated. How it will be activated? By local, okay, hypoxia and local hypercapnia, right? So it will be activated by this local hypoxia and hypercapnia because this vasomotor center is very sensitive to this hypoxia and hypercapnia. Now whenever your VEMC is strongly activated, so it is going to cause a strong activation of the sympathetic system. It is going to cause a strong activation of the sympathetic system. So your sympathetic system will be activated. Sympathetic system activation means what will happen? It will try to increase your blood pressure to a very high level. And that's why I told you that this is the second most potent mechanism for controlling your blood pressure. And what is that? That is nothing but your CNS ischemic response. Getting my point? So this is very simple. Okay, so this is an emergency mechanism, right? It will be activated when your blood pressure is very less. Suppose one person is suffering from road traffic accident and due to huge blood loss, the blood pressure is below 50 millimeter of mercury. Means before that the baroreceptor has tried to increase the blood pressure. Before that chemoreceptor has also tried to increase the blood pressure. But after that, when all this baro, chemo, their effect is gone, now the CNS ischemic response is coming into action. Okay, and that is at the end stage when the blood pressure is below 50, and it is said that this response is very active when the BP is in and around 15 to 25 millimeter of mercury, strongly activated. But what is doing? How this mechanism is activated? This is activated by local hypoxia and hypercapnia, and that is stimulating the sympathetic system to a very strong level that will try to raise your blood pressure as much as possible. Emergency mechanism, right? So I can understand that if this mechanism fails, then there is no one to restore your blood pressure once again. That means the person is going to die if there is failure of this response. And that's why it is said that the CNS ischemic response is an emergency response. Failure of this response will lead to death. This is known as last ditch, okay, last ditch stand or last ditch resort mechanism. Getting my point? So after this failure of this mechanism, there is no one to increase your blood pressure once again, and the person is going to die, right? Now you know that this CNS ischemic response, it has a very important clinical application, and that clinical application is known as Cushing reflex. So this is known as Cushing reflex, right? So what is this Cushing reflex? Let's try to understand. So remember first that Cushing reflex is one type of CNS ischemic response only. So I'm writing here first, this is one form of CIR, CNS ischemic response. But the CNS ischemic response will be activated by some indirect mechanism. And what is that indirect mechanism? There is increase in ICT. So due to any cause, if there is increase in CSF pressure is very high due to any reason, increase ICT, increase in intracranial tension. Okay, so you know that in regional circulation we'll be discussing Monro-Kelly principle. What is that? It is said that this cranium bone is maintaining a fixed volume inside it, and that volume is combination of brain volume, CSF volume, blood volume. Brain, CSF, blood. The sum of this volume will always remain constant. That is Monro-Kelly principle. So whenever one of this pressure or volume is high, here the CSF pressure is high. So what will happen? There will be compression of brain and there will be compression of the capillaries, means blood and brain, other two parts will be compressed. So I can write down like this, that increased ICT means there will be compression on brain also, as well as there will be compression on smaller capillaries which are present at the level of brain. Now whenever there is compression of the capillaries, what is going to happen? There will be creation of hypoxia at the level of brain. And just now we have understood that hypoxia at the level of brain is going to activate the CNS ischemic response. How? This hypoxia of the brain will produce local hypoxia, hypercapnia, because of which it will strongly activate our center, that is the vasomotor center will be strongly activated. And whenever this vasomotor center is activated, now this is indirect form of activation of CIR, right? Now vasomotor center is active means your sympathetic system will be activated. Sympathetic system activation means blood pressure will be high. Which blood pressure? Mainly the pulse pressure is going to be very high. Now, whenever your blood pressure is high, particularly if the pulse pressure is high, we know that our baroreceptor is very sensitive to this pulse pressure, right? Okay, I told you that baroreceptor is most sensitive to pulse pressure. So, it will activate the baroreceptor. Baroreceptor is active. Now, if the baroreceptor is active, what is the effect of baroreceptor activation? Again, okay, so baroreceptor will try to inhibit the vasomotor center. It will try to activate the CIC or cardiac inhibitory center, right? So, baroreceptor is trying to inhibit VMC, try to activate CIC. Now, look at this and try to understand that in this scenario, baroreceptor, although it is trying to inhibit VMC, will it be able to inhibit VMC? Answer is no. Why? Because this VMC is already active and that is activated by local hypoxia and hypercapnia. That is a very strong stimulus for VMC. So although the baroreceptor is trying to inhibit this VMC, but it will not be able to do that. Rather, it will be able to activate the CIC, and we have seen multiple times that activation of CIC means what is the net effect? Net effect is decrease in heart rate. That means this person who is suffering from increased CSF pressure or increased ICT, he will not only suffer from this hypertension, this is number one, he is also going to suffer from this bradycardia, and this bradycardia is by baroreceptor reflex pathway. So there is reflex bradycardia. And not only that, this increased CSF pressure can also causes compression on the respiratory center, because the respiratory center are located at the level of medulla. Compression of respiratory center. Compression of respiratory center will leads to irregular respiration. So irregular respiration is also going to happen. So this is the third feature of this Cushing reflex. Okay, so what we understood? We understood that there will be hypertension. Okay, there will be bradycardia, that is reflex bradycardia, and there will be irregular respiration. Combination of these three features is known as triad of Cushing reflex. This is known as triad of Cushing reflex, right? So now you understood that Cushing reflex is nothing but it is indirect activation of CNS ischemic response where hypertension, bradycardia and irregular respiration is seen. Okay, it is said that this increased pulse pressure is a pathognomic. It has to be present, otherwise it is not Cushing reflex. Okay, and this irregular respiration is the most worst prognostic indicator. Means if it is started, that means there may be the prognosis is very, very bad, right? So this is all about the Cushing reflex that you have to remember. Okay. Now we look at another applied aspect where all these three mechanisms will be combined. Okay. So now I am going to combine all these three mechanisms in this discussion. So just think that person is suffering from severe blood loss due to road traffic accident. Okay, just take this example that due to road traffic accident, continuous blood loss is going from a person, and x-axis I am plotting time and y-axis I am plotting the blood pressure of this person. Suppose I am plotting the mean blood pressure of this person. Okay, this is just for discussion. Okay. So, suppose the mean blood pressure was in and around 100 millimeter of mercury. Due to huge blood loss, the pressure has decreased to suppose 60 millimeter of mercury. So, this was 100. Now, due to loss of blood, the blood pressure has reduced to 60 millimeter of mercury. Now, you have to answer that when the blood pressure of the person has reduced to 60 millimeter of mercury, what is the status of baroreceptor here? What is the status of chemoreceptor here? Could you answer is yes. So here I can say baroreceptor is inactivated. Okay, because working range of baroreceptor is from 50 to 200. But mainly whenever the blood pressure is decreasing from 100 to 60, then baroreceptor is getting more and more inactivation. That's why I'm writing baroreceptor is inactivated. And chemoreceptor, what will happen to the chemoreceptor? Chemoreceptor will be activated because I told you when BP is below 70, chemoreceptor is active. Now, baroreceptor inhibition means I know vasomotor center is going to be activated. Chemoreceptor stimulation means it is also going to activate the vasomotor center. Means both these reflex now stimulating the vasomotor center, and stimulation of the vasomotor center means sympathetic will be stimulated, BP will be higher. That means because of this baroreceptor inactivation, because of this chemoreceptor stimulation, now the blood pressure of this person is going to rise. Okay, it is going to rise, right? So this rise may be 10 to 40 millimeter of mercury. So how much rise is possible? 10 to 40 millimeter of mercury rise is possible. But we have assumed that the blood loss is continuous, right? We have assumed that the blood loss is continuous. Okay, so no one is taking care of the patient who is suffering from this road traffic accident and blood loss is continuously going on. So do you think the high blood pressure will be maintained for long duration? Answer is no, because in other way the blood is going to be lost continuously from the body. So again, there will be drop of blood pressure. Now in this condition, suppose the blood pressure has reduced to more lower condition, that is 40 millimeter of mercury. Now it has reduced to very low condition, that is 40 millimeter of mercury. Now you tell me at 40 millimeter of mercury, what is the status of baro? Baro is the same status, it is inhibited. Chemo is the same status, that is activated. Additionally, another mechanism will also be activated. Now you know that, and that is nothing but CNS ischemic response will also be activated. Now I told you that CNS ischemic response is one of the potent response. It will try to rise your blood pressure as much as possible, Okay, and this kind of fluctuation of blood pressure will continue for some time until and unless there is death of the person. Until and unless there is death of the person. Getting my point? So this way, if you don't treat this patient, the blood pressure, if you record, okay, generally this has been done in experimental animal, and the scientists have proved that this blood pressure fluctuate in a rhythmic fashion, before the death of this person, and this rhythmic fluctuation is happening when the blood loss is continuous from the body. This wave of this fluctuation of blood pressure is known as Mayer's wave. This is known as MAYERS, Mayer's wave of blood pressure fluctuation, or also it is known as vasomotor wave. This is also known as vasomotor wave, right? The peak of this wave generally appears at an interval of 7 to 10 seconds. Okay, so the interval between this is 7 to 10 seconds, and the maximum rise is equal to 10 to 40 millimeter of mercury. This is clearly given in guide, right? So Mayer's wave is nothing but fluctuation of blood pressure. And why this fluctuation is occurring? Which receptor is helping in this fluctuation? This baroreceptor, chemoreceptor, CNS ischemic response. These are the three reflex which is causing fluctuation of this blood pressure. Whenever your blood pressure is continuously going down, 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 this system is trying to raise your blood pressure. Again, your blood pressure is going down. Again, this system is trying to raise. And this way, before death, the blood pressure fluctuation wave is known as Mayer's wave. Okay, that is Mayer's wave. Now, apart from this, blood pressure fluctuation can also occur even during your respiratory cycle also, even during your respiration. Means, if I take inspiration and expiration, blood pressure can also changes during this inspiration and expiration. Why? During inspiration, what will happen? So during inspiration, you are taking inspiration like this. So what is happening? Your thoracic cavity is expanding. Your thoracic cavity is expanding. Inside the thoracic cavity, heart is there. Heart is also expanding. So I can understand that means right atrium is expanding during inspiration. If the right atrium is expanding, it will suck more blood from the inferior vena cava, from superior vena cava. Okay, so this is sucking of blood inside the right atrium during inspiration. So I can understand inspiration means venous return will be high to the right heart. Okay, right side of the heart, the venous return will be high. Left side heart, there will be no increased venous return. Why? Because there will be expansion of the pulmonary capillary also. That pulmonary capillary will accommodate more blood rather than left atrium. So that's why I'm writing that venous return to the right heart will increase mainly. So right heart venous return increase means more blood is on the right side of the heart. So obviously you have a fixed blood of 5 liter. If you take a little bit more blood on the right side, what will happen to the blood volume on the left side? There will be little decrease in left side blood volume, left side venous return. So if the venous return is low in the left side, what will happen to the stroke volume? Stroke volume will be lesser. What will happen to the blood pressure? Blood pressure will be lesser. Remember that during inspiration, heart rate increases. That we'll discuss a little later in this discussion. But during inspiration, if you look at the blood pressure decreases a little bit, right? And opposite thing will happen during expiration. So expiration means there will be increase in blood pressure, right? So if you record this fluctuation of blood pressure during inspiration and expiration, this fluctuation is very, very small. Okay, this is only 2 to 4 millimeter increase or decrease in blood pressure. Obviously, this is only 2 to 4 millimeter increase in decrease in blood pressure. This fluctuation of blood pressure with respiration is known as TRAUBE, Traube-Herring wave. This is known as Traube-Herring wave of blood pressure. Getting my point? So Mayer's wave is the fluctuation of blood pressure when progressive hypotension is happening in the body, and baro, chemo, CNS ischemic response, all of them are trying to increase or decrease the blood pressure. But this Traube-Herring wave means, okay, Traube-Herring wave means this is nothing but fluctuation of blood pressure only 2 to 4 millimeter of mercury during your inspiration and expiration, right? So this is all about your short-term regulation of blood pressure or rapidly acting regulation of blood pressure by baroreceptor, chemoreceptor and CNS ischemic response and their applied aspect, right? Now we have to discuss, apart from this baroreceptor, we have to discuss another thing that is known as low pressure baroreceptor. Okay, so this is the last topic in this chapter. So low pressure baroreceptor, low pressure baroreceptor. Low pressure baroreceptor, they are located in 3 locations. One is atrium, mainly the right atrium. Okay, so atrium I am writing here, mainly the right atrium. Okay, it is also located at the level of pulmonary artery, and it is also located at the level of ventricles. Ventricle means mainly at the level of left ventricle greater than septum, right? Now the receptor which are located at the level of this right atrium and pulmonary artery, they are typically known as low pressure baroreceptor. They are typically known as low pressure baroreceptor, where the receptor which are located at the level of ventricle, mainly the left ventricle and the septum of the left ventricle, they are basically chemoreceptor rather than baroreceptor. So they are basically known as ventricular chemoreceptor. So I am writing here, they are chemoreceptor, and the reflex is known as the coronary chemoreceptor reflex. I will tell you a little bit later. Okay, so for first we are going to discuss this atrium and pulmonary artery baroreceptor. So if I ask you that this receptor located at the level of right atrium, so what is the pressure inside the level of right atrium? That is very high pressure or low pressure? Low pressure. That's why this baroreceptor is working at the level of low pressure zone. Similarly, at the level of pulmonary artery, low pressure zone. That's why this is specially known as low pressure baroreceptor. Okay. There are two types of low pressure baroreceptor. One receptor that is known as type A low pressure baroreceptor, that is activated during systole of the heart, and type B receptor which is activated during diastole of the heart. Two types of low pressure baroreceptor. Now if I ask you at the level of right atrium where it is located, obviously like baroreceptor it is located at the wall of atrium, mainly the right atrium, especially at the level of veno-atrial junction. Veno-atrial junction means at the level of right atrium, suppose this is your right atrium, the area where the superior vena cava is entering, this wall, okay, the area where the superior vena cava is entering, that wall, and the area where the inferior vena cava is entering, this wall mainly contain this low pressure baroreceptor, right? So it is located at the level of wall of the right atrium, veno-atrial junction. How this receptor is going to be activated? Remember, very, very important. Activation of this receptor is done by stretch on right atrium. Obviously, baroreceptor means they are the stretch receptor. They should be stretched. So if you cause a stretch on this right atrium wall, there will be activation of this receptor. So I am writing here, activation will be done by stretch on right atrium wall. How the stretch is going to happen? Stretch is only going to happen if there is increased venous return. So any condition, if the venous return is high to the right atrium, that is going to cause a stretch on right atrium, and that will activate the low pressure baroreceptor. Getting my point? That's why this receptor is known as the volume receptor, because whenever your volume is high, okay, suppose you have given infusion of blood to a person, 500 ml blood infusion. So what will happen to the venous return? High. This right atrium will be stretched and this low pressure baroreceptor will be activated. Suppose you have given certain amount of normal saline to the person, again the volume will be raised and this venous return will be high, this pressure will be activated. That's why this pressure are known as low pressure baroreceptor. They are volume receptor rather than mechanoreceptor. Getting my point? Right. Now if this receptor is active, what is the response? Right. So what is the response? Right. Number one, activation of low pressure baroreceptor will leads to activation of one reflex, activation of Bain-Briggs reflex. It will also leads to decrease production of ADH hormone. So this right atrium has some connection with hypothalamus, okay, hypothalamic nucleus, which is going to synthesize this ADH hormone. So ADH secretion will be decreased and there will be increased production of atrial natriuretic peptide from atrial myocyte. Getting my point? So whenever you stretch the right atrium, many things is going to happen. Many things are going to happen. Number one, it will activate one reflex that is known as Bainbridge reflex, that will be activated, right? Not only that, it will send some connection from right atrium to the hypothalamus by which the ADH secretion will be decreased. Why? Because it has detected that your body fluid is high, your venous return is high. Why will you do with ADH? Depress that. Yes. Not only that, you have huge amount of fluid in your body. You have to excrete more sodium, more fluid, and that's why you increase secretion of atrial natriuretic peptide from atrial myocytes, right? So this is the three response that you have to remember from here, right? Now we are going to discuss what is this Bainbridge reflex. Okay, so Bainbridge, okay, first time he proved that in an animal, if you infuse certain volume of blood or certain volume of fluid, it is increasing the heart rate, okay, if the basal heart rate is low. So this was the observation, that infusion of blood or infusion of saline to an experimental animal, probably after anesthesia, if you infuse blood or saline, the heart rate is rising, and that increase in heart rate is irrespective of the blood pressure. Okay, it is not due to blood pressure changes and heart rate. Okay, that is separate of blood pressure. Heart rate is directly rising, and that observation is known as the Bainbridge reflex. Now we know the explanation of this Bainbridge reflex. Okay, so whenever you are giving infusion of blood, okay, or normal saline, right, NaCl, or any kind of fluid, I should write down fluid rather than NaCl, right? So what is going to happen? Ultimately, it is going to increase your venous return. Venous return increases. That is the first thing. Now, whenever the venous return is increases, just now we have discussed, this low pressure baroreceptor will be activated. So I'm writing here, increased venous return means it is going to activate the low pressure baroreceptor. Now, when the low pressure baroreceptor is activated, from this low pressure baroreceptor, which are located in the right atrium wall, the vagus nerve is the afferent. This vagus nerve will bring signal at the level of medulla, right? So this is vagus, okay? And from medulla, the efferent system, the efferent is nothing but parasympathetic system of the heart, mainly parasympathetic system of heart. Okay, why I'm saying heart? Because note down that in this case of Bainbridge reflex, there will be only affection of parasympathetic of the heart, not the parasympathetic system of the whole body. Okay, it is a very localized response. Okay, whenever this low pressure baroreceptor is activated, okay, it will send signal to the medulla, and medulla will inhibit the parasympathetic system of the heart only, not the parasympathetic system of the other part of the body, not the sympathetic system of the other part of the body. Because of the inhibition of the parasympathetic system of the heart, what is going to happen? The heart rate of the person is going to be increased. So this is known as the Bainbridge reflex. Okay, so this is known as Bainbridge reflex. That's why I told you that initial observation of the Bainbridge is that if you infuse, okay, blood or normal saline, the heart rate is increased, and now we know the reason that heart rate is increasing because of this reflex pathway. There is an MCQ that if you cut bilateral vagotomy, experimental question, particularly in INI set. So obviously in the experimental animal, if you cut the vagus, so vagus is here. So obviously what will happen to the Bainbridge reflex? Bainbridge reflex will be abolished. Means heart rate is not going to increase. But please note down, heart rate will be increased even after cutting off bilateral vagus, although your Bainbridge reflex will be abolished. Why? You know that due to any condition, if your venous return is high, there is a secondary effect, and that secondary effect is direct stretch on SA node, which is located at the level of right atrium. Note down, I told you that right atrium wall will be stretched, that is activating Bainbridge reflex, right? But what about the SA node, which is present at the level of right atrium? Yes, that will also be stretched. If the right atrium SA node is stretched, then there will be opening of some additional channels at the level of prepotential phase, because of which there will be steeper prepotential at the level of SA node. We have discussed this prepotential earlier. Because of the steeper prepotential, there will be increased heart rate also. So basically, now I am saying that if you causes infusion, if you give infusion of blood or fluid, heart rate is increasing by two mechanisms. 60% increment of heart rate is done by this Bainbridge reflex. Another 15% increment of heart rate is done by this direct stretching of SA node. So, if your basal heart rate is 100, 75% increment of heart rate can be possible by these two pathways. One is the direct Bainbridge reflex and other one is the indirect stretching on, right? Indirect stretch on SA node, right? So I can understand, okay, that 75% increment of heart rate is possible by infusion of blood or saline to a person by this two reflex pathway. That's why I was talking about that even if you cut this bilateral vagus also, heart rate increment is possible, but that increment is only 15%. Okay, and that is due to direct stretch on, right? Direct stretch on AC node. Great. Okay, so this is all about the Bainbridge reflex and low pressure baroreceptor. Now you look at here. I told you already that the ventricular wall, they also contain certain receptor. Okay, ventricular wall, they also contain certain receptor, and those receptor are basically chemoreceptor, which are located in the wall of the ventricle, mainly the left ventricular wall and septum. So chemoreceptor means it will be activated in presence of chemical. So remember, activation of this ventricular chemoreceptor can be done by presence of certain chemical in the coronary arteries, because coronary artery is going to perfuse the ventricular wall. So chemical will go to the ventricular muscle through the coronary arteries. So if certain chemical, like for example, very important, serotonin, okay, veratridine, okay, capsaicin, phenyl biguanide. Okay, if any of this chemical is present at the level of coronary arteries, particularly left ventricular muscle wall, then what is going to happen? One reflex will be activated, and that reflex is known as Bezold, okay, Jerez reflex, and that is known as Bezold-Jerez reflex. So very famous Bezold-Jerez reflex. So Bezold-Jerez reflex is also known as coronary chemoreceptor reflex. This is also known as coronary chemoreceptor reflex. Chemoreceptor reflex, and you know the reason, because this is a chemoreceptor activated mechanism, and this chemical should be present at the level of coronary artery. That's why coronary chemoreceptor reflex. At the level of respiratory system, you will find out similar kind of chemoreceptor, and that will be known as the J receptor. J receptor, juxtacapillary receptor. We will discuss about the J receptor in the lung. Their property is similar to like this of the ventricular or coronary chemoreceptor. Now, if this reflex is activated, so what is the responses? Okay, what is going to happen in the body? Okay, responses. Number one, there will be severe hypotension, decrease in blood pressure. There will be severe bradycardia, and number three, there will be coronary vasodilatation. There will be coronary vasodilation. These are known as the triad of Bezold-Jerez reflex. Additionally, there will be a fourth response. There will be apnea, sudden apnea, followed by there will be compensatory hyperventilation. Getting my point? So sudden apnea followed by compensatory hyperventilation along with hypotension, bradycardia and coronary vasodilation. So these three are known as the triad of Bezold-Jerez reflex. Now you must be thinking, is there any clinical applied for this reflex? Okay, so you require certain chemical, and which chemical? This serotonin, veratridine, capsaicin like chemical. So clinically this reflex is rare, okay, but sometimes it happens and it can be dangerous because severe hypotension will happen. So the clinical scenario when this basal gyrus reflex can be activated: number 1, coronary reperfusion therapy. Coronary reperfusion therapy, or you can say during thrombolysis after myocardial ischemia. So whenever there is myocardial ischemia, suppose AMI, the cell is dead and then you are causing the reperfusion therapy. What will happen? This dead cell will be releasing multiple chemicals. There may be serotonin also, there may be release of oxygen free radicals also. This chemicals, this serotonin free radicals is going to activate this basal gyrus reflex, right? So during thrombolysis, during coronary reperfusion therapy, this reflex can be activated. During coronary angiography, okay, so during performance of coronary angiography, okay, whenever you are injecting the dye, this dye sometimes contain impure substances in the form of serotonin or capsaicin. Obviously that is rare, very very rare, but even if it is rare, you have to remember that if this kind of chemical is present, that is going to produce severe hypotension, bradycardia, apnea and all. Okay, so question will be given like this: one person posted for coronary angiography suddenly developed hyperventilation, that indicating the basal gyrus reflex is going on. Number 3, sometimes in case of spinal anesthesia also, okay, spinal anesthesia also, this reflex can be activated, particularly in case of high spinal anesthesia. Particularly if the during the shoulder surgery, if the surgery is done in sitting position and I have given a spinal surgery, a spinal anesthesia which is very high level, that can activate this basal gyrus reflex. And number 4, some of the vasovagal syncope are also due to basal gyrus reflex activation. Okay, although the reason is not known, but it is experimentally proven that some of the vasovagal syncope is also due to activation of basal gyrus reflex, right? So this is all about the low pressure baroreceptor. Now we are going to end this session with a small discussion that suppose you have infused huge amount of fluid in a person, so your ECA volume, extracellular fluid volume, is high, right? And in a person where there is severe loss of ECA fluid volume, we are going to discuss in both the cases what will happen to heart rate, right? Because we have just seen multiple reflexes. So which reflex I have to take in this hypervolemic state and this hypovolemic state? So whenever your ECA volume is high, obviously your venous return will be high, right? So increased venous return means the activation of Bain-Briggs reflex is going to happen. This increased ECA means there will be increase in blood pressure also. Increased blood pressure means there will be activation of baroreceptor also. Now we know baroreceptor activation means sympathetic inhibition, means it will try to causes inhibition of the heart rate. Bain-Briggs reflex activation means it will try to causes increase in heart rate, means I can find out baro and Bain-Briggs reflex, they are acting opposite to one another in this hypervolemic state. Okay, in this hypervolemic state, right? So now we'll look at the other, okay, and then we'll conclude. So in the second one, decrease ECA volume, same thing. There will be decrease in venous return, due to which there will be inhibition of Bain-Briggs reflex. Remember, sometimes decreased blood volume is inhibiting the Bain-Briggs reflex. This is sometimes known as reverse Bain-Briggs reflex. So these terms you should be aware of this term. This is known as reverse BBB, Bain-Briggs reflex, BBR, right? So normal Bain-Briggs reflex means high venous return, Bain-Briggs is activated. Bain-Briggs is inhibited due to low venous return, that is reverse Bain-Briggs reflex, right? So decrease in ECA will also causes decrease in blood pressure. Decreased blood pressure means there will be inhibition of baroreceptor reflex, right? So now you look at inhibition of baroreceptor reflex means vasomotor center will be activated and that will try to increase the heart rate. Bainbridge reflex inhibition means obviously it will try to decrease the heart rate. So again we are finding out two reflex, Bainbridge and Barrow, they are controlling your heart rate in opposite direction. So how the body will decide that the heart rate, net heart rate will increase or decrease. Remember, in hypervolumic state, so I am concluding, in hypervolumic state, okay, always the Bainbridge reflex is dominant than baroreceptor reflex. And in hypovolumic state, the baroreceptor is more dominant than Bainbridge reflex. So now you look at, in hypervolumic state means the first condition here, hypervolumic state, the Bainbridge reflex is more dominant, means although the barrow is trying to inhibit it, but dominant is the Bainbridge reflex. So what will happen? The net heart rate is going to be increase. Okay, and in second cases, hypovolumic state, this is the hypovolumic state, the Bainbridge reflex is trying to inhibit the heart rate, but that is not the dominant. The barrow is increasing the heart rate, that is the dominant. So again there will be increase in heart rate. That's why we know that sudden decrease in volume or sudden increase in blood volume, in both the condition there will be tachycardia. You have seen that if you infuse blood to a person, if you infuse fluid to a person rapidly, that is rising the heart rate of the person. Okay, so that is tachycardia. So if I ask you infusion of fluid or infusion of your saline, okay, or blood causing tachycardia, which reflex is doing this tachycardia? Your Bainbridge reflex is doing this tachycardia. And sudden blood loss from the person, sudden hypotension is also causing tachycardia. Which reflex is doing the tachycardia? That is baroreceptor mediated tachycardia, right? So in both the cases tachycardia is occurring, but in hypervolumic state tachycardia is due to Bainbridge reflex, in hypovolemic state tachycardia is due to baroreceptor reflex. Now we are discussing tachycardia. The last phenomenon you also have to remember, that is known as sinus arrhythmia. Okay, so all these are applied thing. Okay, sinus arrhythmia. So sinus arrhythmia is obviously, it's a physiological condition. Okay, because although this is arrhythmia, there is change in heart rate, but this heart rate changes is originating from the SA node. Okay, that's why this is a complete physiological phenomena, change of heart rate with respiration, that is known as sinus arrhythmia. So now I have to explain that during inspiration what will happen to your heart rate. So I am taking a deep inspiration. Previously we have discussed that during inspiration venous return to the right atrium increases, right? And that's why blood pressure was decreasing on the left side. Now increase venous return to the right side, what reflex is going to be activated? Bainbridge reflex is going to be activated. If Bainbridge reflex is active, what will happen to heart rate? The heart rate is going to be increased. Not only that, during inspiration, okay, there is a direct signal from the respiratory center to the cardio-inhibitory center. Okay, so there is a direct pathway also from the respiratory center to the cardio-inhibitory center, that also causes increase in heart rate. So two cause so far we got, that during inspiration Bainbridge reflex is activated, that is increasing the heart rate. During inspiration there is a direct pathway from respiratory center to CIC is inhibited, and that's why heart rate is also increased. Not only that, the third, during inspiration what happens? There will be expansion of the lung, so the lung stretch receptors, they will be activated, and if the lung stretch receptor is activated, we have seen that are also going to inhibit the CIC, cardiac inhibitory center, and that will also leads to increase in heart rate. So During inspiration, there is increase in heart rate. Obviously, during expiration, what is going to happen? There will be decrease in heart rate. So please remember, if you are taking inspiration, heart rate is rising. If you are exhaling expiration, then your heart rate is decreased. This change in heart rate along with respiration is known as sinus arrhythmia. Okay, arrhythmia. And we have also seen that during inspiration the BP decreases, and during expiration the BP increases. If you record this fluctuation of blood pressure, that is nothing but Traube Herring's wave. This is nothing but Traube Herring's wave. So this is all about your regulation of blood pressure and applied aspect.